Hello, good evening, friends. It's our pleasure to welcome you all again in our series of focused studies in the breast cancer. And we are carrying it out now close to 2 years, and we have been receiving good recognition from all the faculty and the participants. We try to focus on very specific issues that is day-to-day relevance with us. Today, we are going to talk about the localization techniques for non-palpable breast cancers by Dr. Urvashi Jain. And we'll be having another talk about the pathological spectrum of B3 lesions. These are not very commonly discussed in most of the conferences, and we hope that um, uh, this is going to be an update for all of us, including all of us. And I would like to welcome the faculty, Professor Amit Agarwal and Dr. Urvashi Jain. And I welcome all the delegates who have joined to be a part of this program. And with this, I hand over back to the advisors for carrying on the program.
Thank you, sir. So, good evening, everyone. With increase in number of the screen detected patients, it is very important to know the localization techniques for non-palpable breast lesions. There are some conventional methods as well as there are novel techniques also. To discuss all this, we have with us Dr. Urvashi Jain. She was earlier at Guy's and St. Thomas NHS Foundation, London, and currently she is pursuing her International Coercive Fellowship, and she is working in Cambridge right now. Dr. Urvashi, over to you.
Thank you. Thank you so much, Dr. Parikshi, for that kind introduction. Thank you, Dr. Vaishali, Dr. Goel, for this kind invitation. It's a pleasure to be here. I will just try and share my screen. Are you able to see my screen?
Yes, good to go.
Yes.
Okay, perfect. Right, so without much ado, we'll get to the chase. I will be discussing the localization techniques for non-palpable breast lesions, as mentioned. I have no conflicts of interest to declare. Before I start off with localization techniques, I thought it was important to set the tone and the background of this whole issue. So I just put in a few questions which we can perhaps discuss during the panel discussion. I feel that with screening modalities and how things have been over the last few years, it's possibly not just a problem that is now faced in the West when it comes to picking up screen-detected cancers or these non-palpable lesions. And as we all know, breast cancer is the #1 female cancer in India as well currently. So I wanted to actually discuss what percentage of population in your practice, given the advances with systemic treatment and role of neoadjuvant chemotherapy, what percentage of population would you see with non-palpable breast lesions? What are the rates of breast conservation surgery? And if there is a regional variation, because I am aware, having trained at the Tata Memorial earlier, that there can be a lot of difference in variation, and there can be a lot of variation in practice given different regions as well. And what is the current practice in terms of margin status as well? I know a lot of centers have frozen section intraoperatively, and if that really impacts how we look at margins now, and whether scheduling is purely a problem of the Western world, or has it become an issue in developing countries as well? And I've also felt that things changed since the pandemic, at least for us in the UK and for what we experienced. I think there is somebody talking. Not sure. Okay. Right. So we faced quite a few issues in terms of how we had to schedule patients and operate them off-site during the pandemic, given that our institution was considered not to be a clean space in terms of patients who were admitted with the pandemic, with the COVID-19 back then. So things kind of also changed when we looked at how we had to localize these patients or when they had to go for nuclear medicine injections. Just to give a perspective of the proportion of breast cancer patients and at what stage they're diagnosed, so about 80% of them are diagnosed at stage 1 and 2. And more than 30% are non-palpable at diagnosis. This is data from Cancer Research UK. And we all know that age-old practice for about 50 years has been localization with wires, which was first described by Dodd in 1965. And it does rely on correct placement by the radiologists. We all know the drawbacks. It can be very cumbersome and uncomfortable for our patients. Scheduling does become an issue. We have to make sure that these patients do get operated on the day and are scheduled in a way that they can have their wires and are posted for surgery in due time in theaters. There is also a possibility that the tumors may not be localized properly based on how the wire is placed. We're also aware of migration that can happen with the wire, and that can also affect the surgical technique. And it's important that we check these radiological specimens once they are taken out to ensure that we've got the correct target. And there is about 2.8 to 53% positive margin rate, which is again quite a large variation that we've seen from studies. So these were the conventional wires that were used, or we still use some of them. As I already mentioned, those were the drawbacks. So coming to the fact that are we really justified in carrying out with these age-old practices of localization in this century when we've moved our focus towards oncoaesthetics, quality of life, patient satisfaction, experience, and patient-related outcome measures? And that's what possibly led to some innovations. Some clever minds came up with other innovative methods of localization. And the basic fundamental, of course, revolves around the fact that we all evolve with time and learn from mistakes and failures, and then we fine-tune and refine for better production to achieve near or almost, if not near absolute, if not absolute, then almost near perfection. So the question really that begs here is, have we got to the point of achieving that near perfection with these novel techniques for localization of non-palpable breast lesions yet? And how do we define this near perfection in this kind of situation? So let's have a look through some of the discoveries and what is currently available on the market today globally. So here is an overview of discoveries and what's available. We'll go through each one of these in bits. So let's start with the most simple and basic method of intraoperative ultrasound. We all pretty much know how this works. It's very easy, it's non-invasive, it's a safe technique. There has been enough data that shows that there have been higher rates of negative margins achieved with this method, lower resection volumes. As a surgeon, of course, it makes you very independent of the radiologists. We are able to look at it real time intraoperatively during the surgical excision. But of course, there is a learning curve. We don't always have radiology as part of our armamentarium while we are going through our training. A lot comes with experience, and that is to some extent a drawback with this technique. But of course, not to look down upon the benefits. There is enough data in terms of margins. As you can see, for lesions as small as 4 and 5 millimeters, there's been 100% negative margin excision from studies listed here in the Breast Cancer Research and Annals of Oncology. And there has been comparison studies that have taken place with intraoperative ultrasound and wire-guided localizations, where you can see that the negative margins were much lesser in the intraoperative ultrasound group as compared to the wire localizations. Coming to other techniques now, starting with radio-guided occult lesion localization. This was developed in 1998 at European Institute of European Oncology in Milan. It utilizes a non-specific radioisotope which is injected intratumorally preoperatively within the lesion and can be detected by a handheld gamma probe. It has very good rates of tumor localization. This method can also be adapted to doing a sentinel lymph node biopsy by injection of the radiocolloid peritumorally or subdermally. And hence it can be used for both the breast and the axilla. When it is used for the sentinel node as well, it is called SNOL. Back in the day, they started this with radio labeling human albumin. And you can see some of the images here that were obtained by injecting this. So moving on, this is a technique where radio occult lesion could be localized with an iodine seed and is called Rollis. This was described by Gray et al. And presented at the American College of Surgeons Congress. This seed originally used by radiation oncologists, was used by radiation oncologists for prostate cancer, and it emits a source of radiation, which is 27 keV and has a half-life of about 60 days. Moving from infiltration of these products, we then came to having a radioiodine seed. This is a percutaneous injection of a small titanium seed, which is radio labeled. It's a separate injection of radiocolloid, which you would need to do a sentinel lymph node biopsy. This has a half-life of about 60 days, so it can be put in at least 4 months before the surgery. Seed migration is rare in these cases, and there is a potential advantage given the fact that it can be used for sentinel lymph node biopsy as well. Now, what are the risks and risks involved with these radioactive substances? There is definitely a risk of radiation, and of course, there are legislative issues, and licensing is a big problem if the seed goes missing in pathology or while performing the procedure. Mainly due to this, we then moved from radioactive substances to non-radioactive substances. Just to give you an overview of some of the studies comparing these techniques as well, keeping wire-guided excision as the control or standard. There were similar outcomes with the 3 methods. However, wire localization was still considered to be superior as compared to these radioactive substances or seeds. And this is some of the data looking at margin status for roll versus wire localized excisions. And you can see that there were significant differences in terms of margin positivity in some of the trials as well. And roll didn't take up as much when looked at this data, and also given the fact that it wasn't very easy for a lot of centers in terms of having it licensed and go through the legislation process. So coming to the non-radioactive localization methods now, I will start with MACSeed. I'm sorry about some of the background noise. I'm actually away on a holiday. Sorry. So looking at MACSeed, this is a paramagnetic seed placement of about 5 millimeters of steel and iron oxide seed. This is visible on ultrasound as well and can be placed well in advance prior to the surgery. It also gives you an idea of distance between the seed and the probe, and there is a good sensing zone that can be established while you're performing this procedure. And as mentioned, this is non-radioactive. However, it does come with certain disadvantages as well, which I've listed here. Bracketing could be an issue sometimes if the lesions are too close and you want to excise them en bloc, and if the distance between the two lesions is less than 2 centimeters. But most often with experience, you are able to do wider excisions and localize more than 2 lesions as well, but keeping in mind that the distance between them is not very close. The other issue with these paramagnetic or magnetic seeds is the fact that they cause MRI bloom, and most patients that go on to have neoadjuvant chemotherapy, and for centers who do use MRI as the modality for looking at response, this can cause MRI bloom, which cannot really give you a true picture of how the response is, and that very often is a major setback. So it can't be placed right before you start the neoadjuvant chemotherapy for patients. And also the fact that this is paramagnetic, it works on the principle of magnetic signals. So if you have instruments that are magnetized, then those cannot be used. You would have to use plastic retractors or non-ferrous instruments when performing these techniques. Some of the data that we have with MACSeed, there has been enough data now in terms of feasibility and safety. This was one of the largest studies in the UK that was done to look at feasibility, and there were about 35 participating units from UK with about 2,300 patients, and it showed a good lesion localization rate of about 99.8% with MACSeed as compared to wire, which was 99.1%. And they did establish good accuracy in terms of localization. Coming to the other method now, which is also based on a similar concept. This is called Cetus Pintuition by GPS Detect. It is basically a guided pinpoint software which provides real-time directional guidance using audio and visual feedback, as you can see in these animations on your right. It's very intuitive, non-radioactive, so convenient to use from that perspective. About the same size as a MACSeed. It's about 5 millimeter long. It's a magnetic seed. Again, it allows you freedom of scheduling. You can place the seed inside up to 180 days prior to the planned procedure. It does not lose signal over time, and it can be used for both breast and axilla. That's another advantage with both the MACSeed and the Pintuition. This particular apparatus and technique also has something called as a target lock feature, which is unique. As you can see in the animation below on your right, there is a bullseye that comes up, which shows you exactly where you are. And when you're perfectly aligned just above the seat is when it will give you the bullseye signal. Again, disadvantage with this technique, similar to MACSeed, bearing of course bracketing and similar issues in terms of instrumentation and MRI bloom, given that again it has magnetic properties. this is just some of the pictures radiologically of how the seed looks like on the mammogram and the ultrasound. This is one of the nodes with the seed that has been taken out. There is some early data that we have with serous pincution. This was presented in SO last year, which has shown good safety and feasibility as compared to the conventional techniques. Now coming to a different innovative technique of localization. This is a localizer radio frequency method. This basically works on the fact that you're able to tag these lesions, which makes it a lot easier when you have to target more than one lesion. So each of these lesions has an ID or tag. So if you have more than one lesion, you'll know exactly which lesion you're targeting or picking when you're performing wide local excisions or excisions of these lesions. There is again no radiation, and there is enough freedom with scheduling of up to 30 days. It will also show you the distance to tag on screen. In terms of disadvantages, well, we don't have enough data really that has reported in terms of comparison or use when compared to conventional methods. And the other thing is cost. In terms of MRI, again, we don't have enough data, but it seems to be MRI friendly in terms of the fact that you wouldn't really have an MRI bloom with this method since no magnetic properties are used. And then coming to another method of localization, which is called the Savvy Scout. This was one of the first ones to be cleared by FDA in 2014 as a non-radioactive, non-wire localizer from Sienna Medical. It uses a radar reflector, which is activated with infrared light, and the reflector is passive until activated from the console by a handpiece, and it emits pulses of infrared light and radar wave signals, and that is how it is used to identify lesions and target them. This has a length of about 12 millimeters, and it has antennas. So given the fact that it's got these antennas, they can very often come in the way when you're performing surgical excisions. If your cautery comes too close to these antennas, then it may not work and you won't get the signal that you need to target the lesion. That's one of the drawbacks in terms of doing the localization with this technique. It can, of course, it has good flexibility with scheduling as well, because you're able to put in the Savvy Scout much before the planned procedure. The major advantage, if you compare this to the magnetic seeds, is the fact that it is not known to have any MRI bloom. So it can be put in before starting neoadjuvant chemotherapy, as that is not likely to cause any issues when you're looking at response, or if you want to do an MRI later on in these patients to look at response. And some of the early data from that is very encouraging. So just to give you a summary and overview of all the techniques that I have discussed so far, there are some pros and cons to each technique, and this is still very much evolving. A lot of new techniques are still looking to be established, or there are companies that are looking at how they can make the already existing seeds or techniques more compatible for surgeon and patient use. So what would be the ideal localization technique for these non-palpable lesions in the breast? So coming to what I first started with, what would we really describe as near perfection, if not absolute? We want successful localization. We want to be able to bracket more than one lesion. if we can serve the purpose of localizing the breast and axilla as well, again, that would have implications on health economics and would be very cost effective. It should be something that is replicable across units, is intuitive, has a short learning curve. We are able to get good negative margins when performing wide local excisions, which will eventually lead to lower reoperation rates, and is, of course, very comfortable for our patients. And in terms of preferred characteristics, we would want it to be radiation free, not have MRI blooms or blind spots that could hamper our clinical utility. Something that could be placed at the time or instead of a coil. Again, all of these factors would also play a huge role in health economics and, of course, a lot of comfort for the patient. It would be a one-time procedure, which would possibly be something that most patients would be very happy to go with and tolerate. This would be, again, the other thing that we would look at is favorable cosmesis based on the fact that the excisions are smaller with good negative margins and with least post-operative complications and global scheduling, global feasibility and ease of scheduling with these techniques. So in terms of future prospects, this is a study that has been planned in the UK. It's called the IBRA-NET. It's a national audit of localization techniques for breast lesions. The first ever report that came for MACSEED was from IBRA-NET as well, where they looked at about 2,000 patients. And now the aim is for them to put all innovative devices and techniques into one audit to see how we can evaluate each of these techniques and as a network establish safety and efficacy in terms of data collaboratively. So coming to the end, take-home messages. At the end of the day, it is really about patient comfort, experience, good healthcare delivery, and keeping with good economics, which should, of course, be paramount for all of us clinicians. The basic concept remains the same. The technology may differ. It is important that we understand pros and cons of each of these methods, as there are several in the market. And you do what works best for you in your practice, keeping with all of these things that I stated above. And it's important that we maintain an audit to be able to establish safety and good practice when testing any new innovative technology. With that, I would like to thank my patients, my mentor, Mr. Kothari, and my team at GUYS, where I've had most of the experience with some of the techniques. We currently use MACSEED for most of our patients for the non-palpable breast lesions. And thank you to the team at FSIBC for inviting me.
Thank you, Dr. Urvashi. That was indeed a wonderful talk. And you comprehensively covered the whole topic. Thank you so much. Next in the row, we will discuss B3 lesions, which are the breast lesions of uncertain malignant potential. To discuss the pathological spectrum and the clinical implications, I would now like to invite Dr. Gaurav Khanna, who is Assistant Professor at Amrita Hospital, Faridabad. Dr. Gaurav Khanna, please.
Yes, good evening, everyone. Thank you, Dr. Urvashi, for updating us with the latest technologies, advancements in detecting these non-palpable lesions. It was really a very eye-opening talk. And should I share my screen? Should I start my presentation?
Yes, sir. You
Yes,
can share
please.
the screen.
Yeah.
Is it visible?
No, sir, still not.
No, not yet.
Is it visible now?
No, sir, it is a Zoom screen you have shared. You need to share the presentation window, sir.
Yeah,
Yes.
it is
Put it
now.
full screen. Full screen.
Full screen.
Yes. Good
Yes.
to go, sir.
So, first of all, thank you everyone, and thanks for
Okay, Gaurav,
considering.
you can see that at the bottom, you can see there is the hide button.
Oh yes.
Yeah, perfect. Good to go, sir.
Yes. So thank you everyone, and thanks the team for considering me to present this very wonderful, really wonderful topic. Actually, this topic is very extensive, and I hope that I will be able to convey the important pathological aspects of all these lesions, the B3 lesions, and I'll try to discuss them in brief and still share all the important pathological aspects of these lesions. So basically, the B categorization of the breast lesions, the classification was proposed by the UK breast screening program, and they divide these lesions on the basis of the findings in the core needle biopsy or vacuum assisted biopsy. And they divide the lesions into five categories. The B1 remains the non-diagnostic or the normal breast tissue which needs further assessment. B2 are the benign lesions, and B5 lesions are the straight away the malignant lesions which need surgical excision. In between the B2 and B5 are the two lesions which are borderline, and B4 lesions are still suspicious for malignancy, which again need surgical intervention. But the B3 lesions are the lesions which need a multidisciplinary team approach or multidisciplinary team discussion, or certain because the lesions are really dubious and really difficult to diagnose in the core biopsies. These lesions specifically include ADH, that is atypical ductal hyperplasia, lobular neoplasia, flat epithelial atypia, radial scar, papillomas with or without atypia, phyllodes tumor, some spindle cell lesions, or mucosal. So these lesions are called as lesions with uncertain malignant potential. The frequency of B3 lesions have increased since there is increase in the breast screening programs by mammography, and it varies from 5 to 17% of cases patients undergoing screening program. And the ADH is the most frequent lesion of all these B3 lesions. B3 lesions are important because they are risk indicators and they are also non-obligate precursors of malignancies. And they are risk indicators not only on the ipsilateral breast cancers but also on the contralateral side. Some authors like to divide these B3 lesions further into two types, like B3 lesions with atypia or B3 lesions without atypia. The lesions with atypia like atypical ductal hyperplasia, flat epithelial atypia, and lobular neoplasia like atypical lobular hyperplasia and lobular carcinoma. Because these lesions in 11 to 35% of cases are associated with increased risk of in situ or low-grade hormone-positive invasive cancer. These lesions may turn out to be cancer, may turn out to be invasive breast cancer, but still they remain the low-grade hormone-positive carcinomas. These lesions are called as high-risk lesions or high-risk B3 lesions. Then some authors like to divide these B3 lesions into where the surgical, where the lesions have tendency of incomplete sampling, or the lesions which can be completely removed with the help of vacuum assisted biopsy or on a core needle biopsy. So lesions which have tendency of incomplete sampling are like cellular fibroepithelial lesions, papillomas with or without ATP, and radial scar. So different authors have different approach to divide these B3 lesions, but this yes, the important thing is to identify these B3 lesions. So coming to the first, the most common type of B3 lesion is atypical ductal hyperplasia. This is the most frequently diagnosed B3 lesion in during the breast screening program, comprises around 2 to 14% of biopsies in screened population. And although mammography does not have very distinct features, non-specific calcification may or may not be seen, and there may be some non-mass enhancement on MRI. Microscopy is very important in atypical ductal hyperplasia. It involves evaluation at three steps. Architecture and cytology are the two important aspects in every histopathology, in study of every case of histopathology. To diagnose ADH, the extent is important. So architecturally, we used to see the rigid bridges within a duct. We used to see rigid bridges, arcs, and the arcs have cells oriented perpendicular to these arcs, and the punched out lumina. I'll show you the images like this. This is the picture. The lower three pictures are of atypical ductal hyperplasia. We can see these are punched out spaces within a duct, and the cells are monotonous. So on cytology and architecture, it's very important that we see a monotonous kind of population of cells. We can see here these are all the cells are similar looking, and the cells are arranged perpendicular to these arches, and this is punched out appearance, and the punched out lumina are present throughout the duct, distributed throughout the duct. Here, the above three pictures are of usual ductal hyperplasia, which is a benign lesion. Here we can see the punched out spaces are present at the peripheries of these ducts. Here the punched out lesions are present throughout the ducts. And here the cell population is heterogeneous because they are also composed of myoepithelial cells and ductal cells. And here the myoepithelial cells are missing in the ducts and they are present only at the periphery. So here there is monotonous population lacking the myoepithelial cells with sharp punched out spaces distributed throughout the duct, and the cells oriented perpendicular to these arches. Then sometimes there may be papillary formation. These papillae are actually these papillae in ADH, in atypical ductal hyperplasia. The papillae lack the fibrovascular core. Actually, these are micropapillae, and these micropapillae also have very characteristic. We can see that the attachment of the papilla at the duct is very narrow, but it has a broad tip. So basically, the papilla are narrow base, broad tip. Here also we can see the narrow tip and narrow base and broad tip. While the papilla in the usual ductal hyperplasia have broad base and narrow tip. And again, we can see the cells are a heterogeneous type. Here the cells are monomorphic. So this is a very important to differentiate. This is very important for the breast pathologist to differentiate whether we are dealing with whether the pathologist is dealing with a usual ductal hyperplasia or atypical ductal hyperplasia. Then atypical ductal hyperplasia, the cytology and architecture is exactly similar in low-grade DCIS. The only difference lies in the extent. If the lesion is less than 2 mm, it will be called as atypical ductal hyperplasia. If there is involvement of more than 2 duct spaces, it will qualify for low-grade ductal carcinoma in situ. Similarly, IHC also is very helpful to differentiate between usual ductal hyperplasia and atypical ductal hyperplasia. As I told that usual ductal hyperplasia is comprised of admixture of myoepithelial cells, so there will be presence of CK5 by 6, which is a high molecular weight cytokeratin and is a marker of myoepithelial cells. And because the cell population is heterogeneous, so ER positivity will also be heterogeneous. Unlike in ADH, where the ER positivity will be homogeneous, strong, diffuse, and CK5 by 6 will be lacking. Here we can see the IHC differences. In UDH, CK5 by 6 is strongly and diffusely present throughout the proliferation of the epithelial cells. While here in ADH, here in this part, in the right half of this image, CK5 by 6 is lacking. And similarly in ER, estrogen receptor is showing heterogeneous positivity in usual ductal hyperplasia, and while it is strong and diffuse positive in atypical ductal hyperplasia. So usual ductal hyperplasia can be differentiated from atypical ductal hyperplasia only with the help of good study of morphology along with the IHC. And the extent, with the help of extent of involvement, we can call whether we are dealing with the atypical ductal hyperplasia or DCIS. So what happens for the management in ADH or atypical intraductal epithelial proliferation? This is term used by some authors. Some authors prefer to call ADH as atypical intraductal epithelial proliferation. So when there was first international consensus conference on B3 lesions, they suggested a follow-up without surgical intervention for all ADH lesions, considering that the lesion has been removed through percutaneous biopsy. But the upgrade rate was varies between 10 to 20%. Most of the studies revealed that the upgrade rate in ADH to invasive carcinoma or high-grade DCIS is 14%. But this 14% upgrade rate was too high to follow this recommendation, that without surgical intervention and simply follow up. So second international consensus conference revealed the importance of surgery for ADH management. And clinical surveillance was considered in particular cases only after multidisciplinary evaluation, that that the lesion has been completely removed and other risk factors are not there. Then only clinical surveillance should be the priority. Otherwise, surgery should be done. According to UK National Health Service Service Best Screening Program, vacuum assisted biopsy, they prefer a little conservative approach. They prefer vacuum assisted excision following vacuum assisted biopsy. If a diagnosis of ADH is given on core needle biopsy or vacuum assisted biopsy, it should be followed by vacuum assisted excision if there is any persistence of the lesion. Then follow up in cases where the lesion has been removed completely, and open surgery is recommended only when there is some pathological radiological discrepancy, or it should be dealt with individual basis. Whether there are some other risk factors and the patient is old age or some lesion is still there, then only surgical intervention should be done. So UK prefers a little more conservative approach, and they introduce vacuum assisted excision of the lesion and then follow up. While according to second international consensus, surgery should be the preferred mode in if ADH is being diagnosed. Then coming to the second entity of B3 lesion, which is lobular neoplasia. This is also very interesting pathology. Pathology wise, like it comprises atypical lobular hyperplasia and lobular carcinoma in situ. Lobular carcinoma in situ have three variants: classic, pleomorphic, and florid. Typically, the classic one is only included in the B3 lesion. Pleomorphic and florid variants comes to they fall into B5A category because they are highly associated with invasive malignancy. In fact, 87% of cases of these pleomorphic and florid variants of lobular neoplasia have invasive malignancy, and 84 to 100% of cases the invasive malignancy is invasive lobular carcinoma. So how to diagnose a atypical lobular hyperplasia or invasive lobular carcinoma? So basically, in atypical lobular hyperplasia, unlike in ADH where we used to see the cytology and architecture and extent, here the extent and cytology is important. Architecturally, we don't see any specific findings. It's only that the acini are distended, and the extent of acini, distended acini matters. If the acini, if more than 50% of the acini are distended with monotonous discohesive population of cells, like in this picture, it will be called as LCIS. And if less than 50% of the acini are distended, it will be called as atypical lobular hyperplasia. Then how to call that the acini is distended? This is also variable amongst different authors. Some authors believe that. Am I audible?
Yes.
Yeah.
Okay, should I continue? I hope I'm not going too fast or too slow.
No, please go ahead.
Okay. Some authors believe that if an acini is having more than 8 cell proliferation, it should be called as distended. Here we can see these acini are having only 2 to 3 cells. So these acini are not distended. However, in this we can clearly see that it is more than 8 cell thick. So these acini are distended and they are having monotonous population, monotonous discohesive population. So this is a picture of atypical lobular hyperplasia. Here we can see that the lobules are very much distended with monotonous discohesive population of cells along with these single Indian file fashion of monomorphic monotonous population of cells which are infiltrating in the stroma. So this is LCIS with invasive lobular carcinoma. And here we can see the entire acini is distended with monotonous population. Entire TDLU is distended. Here we can see the lobularization, cancerization of the duct as well. So in cytology, we discussed that the population should be monotonous, it should be discohesive, and actually there are two types of cells. Type A cells, which are 1 to 1.5 times the size of lymphocyte nuclei, which we saw just now. Or sometimes there may be type B cells also, which are little bit larger than the conventional type A cells. So extent, I told you that expanding or distending more than less than 50% of the acini in a TDLU, we will call it as ALH, atypical lobular hyperplasia. If more than 50% of acini are expanded, it will be called as LCIS. Pagetoid extension to the duct may or may not be present, and it does not have very much clinical significance. Yes, if there is ductal and lobular involvement both, then the risk is higher. Risk of upgrade is higher when both ducts and lobules are involved. And relative risk is 4 to 5 times in a woman than without ALH. Absolute risk is 1% per year, and cumulative incidence of 30% at 25 for 25 years. This is also important, pleomorphic and florid. In pleomorphic lobular carcinoma, the size of the cell is 4 times the size of the lymphocyte nucleus, unlike in type A cells, where in conventional or in classical lobular LCIS, where the cell size is 1 to 1.5 times. Here, the cells are almost like high grade DCIS. And the immunohistochemistry panel in pleomorphic LCIS is also very different. Their majority of the cases are ER negative, and they may be HER2 positive. They may be positive for androgen receptor. P53 is commonly mutant, and they have high Ki67 index. Now, the another variant of LCIS, which is florid type, this is also included into 5A category and is excluded from B3 category. When to call a lobular carcinoma in situ as florid? When there is no intervening stroma in between the distended acini, and the acini is distended with 40 to 50 cell thick population. Then we call it as florid LCIS. They have hormonal profile similar to classic LCIS. It's only on morphology we can distinguish that we are dealing with a florid LCIS. Now, management in lobular neoplasia, as we discussed, the upgrade rate is highly variable. So there was no well-defined consensus to how should they be managed. But recent studies show that there is 0 to 4% upgrade rates. Currently, the second international consensus on B3 lesion, especially the lobular neoplasia, it says if the classical lobular neoplasia is visible on imaging, excision should be done with vacuum-assisted biopsy, and only surveillance if there is no pathological radiological discordance and there is no residual lesion. So vacuum-assisted biopsy, because the size is very small, only few TDLUs are involved. Vacuum-assisted biopsy is adequate enough. According to UK breast screening program, vacuum-assisted excision should be the second assessment, and then if there is no additional lobular neoplasia or the lesion was unifocal and there is no discordance and there is no suspicion of malignancy on follow-up, then imaging follow-up on imaging is adequate, and surgery is kept as the option only when there is surgico-pathological discordance or there are high chances that the lesion have tendency to upgrade to, or we are dealing with a pleomorphic or florid LCIS. Then only surgery is recommended. So close imaging followed with breast MRI should be considered when there is other high risk factors present. And we have already discussed that the variants of lobular neoplasia, that is pleomorphic LCIS and florid LCIS, they should undergo open excision. Now coming to flat epithelial atypia, this is also very interesting entity. So if we remove the architectural features from ADH, we can define flat epithelial atypia, because the architectural, as you can see here, the native ductal epithelium is being replaced by few to several layers of monotonous population of atypical epithelial cells, and some of these glands are showing apical snouts as well, and the lumina is filled with secretion. So basically, flat means there is no papilla, there is no arcades, bridges, or micropapillary formation which were there in ADH. So they are absent. That's why it is called as flat. But nuclear atypia grade is similar to low grade DCIS or ADH, and IHC pattern of flat epithelial atypia will also be very much similar to ADH. That is, they will be ER positive and CK5/6 will be negative within the duct. Again, this can also be considered as non-obligate precursors of low-grade DCIS and invasive carcinoma, but the frequency is even less than ADH, and it can be considered as the first step of carcinogenesis pathway, because the phenotype and cytogenetically it follows the continuum of low-grade DCIS and invasive carcinoma. So this can be considered as the earliest step of invasive carcinoma. So that's how it becomes a non-obligate precursor. And there is one more entity. If the ATPI is missing and only hyperplasia is there, the cells are showing columnar cell change and with apical snouts, it is called as columnar cell change. So basically, if there is columnar cell change along with ATPia, it will be called as flat epithelial ATPia. So management in flat epithelial atypia, as there is very slight increased breast cancer risk, only 1 to 2 times, which is substantially lower than ADH. So upgrade after core natal biopsy or vacuum assisted biopsy is usually in the form of ADH or low grade DCIS only. And invasive carcinoma which is very less commonly seen in flat epithelial atypia, and if it is seen, it is mostly low grade type only. So current guidelines are surveillance if the lesion is small and radiologically the lesion has been completely removed by core needle biopsy. Only surveillance is sufficient, and surgical intervention is required when there is wide area of microcalcification or there is some discordance between pathology and radiology. Now coming to the next entity, which is radial scar and complex sclerosing lesion. So radial scar is again very important radial because it can mimic invasive carcinoma on radiology. It has a very classic morphology, the central fibroelastotic core with the entrapped ducts. Some are showing ductal epithelial proliferation. This epithelial proliferation is usually of usual ductal hyperplasia type, but sometimes it may be of ADH type or it may sometimes be associated with low-grade DCIS as well. Then it becomes clinically important whether it should be whether it should be dealt with the surveillance or it should be surgically excised. So basically, central fibroelastotic core and trapped glandular structures with or without proliferation, usually which is UDH type, apocrine metaplasia can be seen. Generally, radial scar are less than 10 mm size. They are classically non-palpable and they are usually complex sclerosing lesion are usually more than 10 mm size. So we have discussed why it mimics invasive carcinoma because of this central fibroelastotic core and irregular spiculated margins, borders. So management in radial scar, as per the second international consensus conference, radial scar or complex sclerosing lesions which are visible on imaging should undergo therapeutic excision with vacuum assisted excision, or when there is associated atypia, then surgery should be advised. If and according to National Health Screening Breast Screening Program, if there is no atypia, then there is no need for imaging follow-up. And if there is atypia, then or upgrade to DCIS, then surgery is recommended. So basically, more or less, they both are on same page. If there is no atypia, then just imaging follow-up is adequate. If there is atypia, surgical excision should be done. Now coming to the papillary lesions. Papillary lesions comprise around 3% of all breast malignancies. They are more common in older age and they are rarely seen in adolescents. Commonly, they are clinically very evident because of the torsion of the cores and they present with bleeding ducts. And they are classified as solitary interductal papillomas. They may be central, they may be peripheral. Peripheral are more commonly associated with atypia, while central are usually benign. And central are usually subareolar in location and they spare the terminal ductal lobular unit, while the peripheral involves the terminal ductal lobular units. Papillomas with atypia, they may show ADH or lobular neoplasia, and these are included in B3 category. Then there is papillary DCIS, then there is papillary carcinomas. Papillary carcinomas can be encapsulated, they can be solid papillary carcinoma, then there can be invasive papillary carcinoma. Then the B3 lesion, which are papillomas with atypia, we will be discussing this entity only. The papillomas with ADH or papilloma with DCIS, this is also very important to differentiate. So basically there will be a papilloma. We can see here, this is an
Dr.
interductal
Gaurav,
papilloma. Here we can see some
Dr.
apocrine
Gaurav, can you
change.
hear me?
Yes.
Sir, how much still you will take time if you don't mind?
It's only 3 to 4 slides left.
No problem, sir.
So papillomas with ADH, the atypical epithelial population, if it is less than 3 mm or less than 30%, then it is called as papilloma with ADH. If it is more than 3 mm, we call it as papilloma with DCIS. If the nuclear grade is high, then we call it as papilloma with DCIS irrespective of the size. So management of papillary lesions, then again, if there is atypia, papillomas without atypia, then there is no need to undergo surgical excision. If the histological sample is sufficient and there is no discordance between pathology and radiology, and when there are peripheral papillomatosis or multiple papillomas, then surgery is recommended. As per the current guidelines from second international consensus, if a papillary lesion is visible on imaging, then it should undergo vacuum-assisted excision. Larger lesions that cannot be completely removed, then surgery is recommended. According to National Health Services Breast Screening Program, vacuum-assisted excision is the second assessment tool where lesion without atypia is diagnosed. And if there is papilloma with atypia, that should undergo surgical excision. It's similar to other lesions. If there is atypia, surgery should be recommended. If there is no atypia, then provided there is there is radiopathological concordance, then just follow up is adequate. I should skip this slide. Bland looking spindle cell lesion, because they need extensive study with the help of immunohistochemistry. They should be better avoided in B3 lesions, and they should be extensively studied. But yes, Hyloid's tumor is very important, because sometimes the fibroepithelial lesions are confusing, whether we are dealing with whether pathologist is looking at a fibroadenoma case or a phyllodes. So very important clinical aspect is they are large size, or they show rapid growth. Mammographically, sometimes they may not be differentiated, and they are similar to fibroadenomas, and they are commonly seen in 40 to 51 years of age, and Asian countries they may present in younger age as well. So benign, the most frequent type of variant of Hyloid's tumor, or borderline phyllodes belong to B3 lesions, while malignant phyllodes belongs to 5B category. So they are basically big, ovoid, high opacity mass with irregular edges and usually lobulated. Clinically, they are very easily distinguished from fibroadenoma, generally big size lesion with a history of rapid growth, overlying skin is stretched. So this is the classical picture of phyllodes. We can see here papillary fronts, the stroma is quite hyperplastic and the ducts are compressed with the proliferative stroma. So this is a benign phyllodes. Sometimes we can see the periductal condensation or periductal myxoid change, like in this case. This is also quite frequently seen in fibroadenoma. Because of this characteristic feature, it becomes confusing for fibroadenoma. So sometimes it becomes difficult on a core needle biopsy to whether we are dealing with a fibroadenoma or a phyllodes. In those cases, fibroepithelial lesion, benign fibroepithelial lesion is given or to be on the safer side. So management says management of Hyloid's tumor, as per the second international consensus, whenever a fibroepithelial lesion is seen on core needle biopsy, which cannot be exactly characterized, open surgical excision with clear margins is recommended. And according to a National Health Breast Screening Program, a surgical excision with clear margins should be done. So the take-home message, considering the management part, is traditionally the high-risk lesions were managed with surgical excision because of their low but latent potential of upgrade to malignancy. As per the most recent guidelines, they recommend a bit more conservative approach because of the vacuum-assisted excision, as vacuum-assisted excision allows more extensive tissue examination, as well as which helps in which is important diagnostically as well as therapeutically, because approximately 4 gram of the tissue is removed in vacuum-assisted excision, as the needle size is larger and the more tissue is removed. So the smaller lesions like ADH, like flat epithelial atypia or the ALH, atypical lobular hyperplasia, these lesions can be completely removed with the help of vacuum-assisted excision. So this spares the open surgery and can be avoided easily. And radiological follow-up in all the cases where the patients are diagnosed with B3 lesions with the help of mammography and breast MRI should be done. And multidisciplinary approach should comprising of the entire breast surgical team, like oncologists, including the oncologist, radiotherapist, pathologist, everyone. They should sit together and decide whether the patient qualifies for the surgical excision or imaging surveillance is adequate. These are my important references. I referred the WHO classification of tumors, the 5th edition, and this article, a beautiful article from Memorial Sloan Kettering Center, and this is my hospital, Amrita Institute of Medical Sciences. This I joined recently. This institute, earlier I was at Fortis Memorial Research Institute in Gurugram, and thank you so much for considering me and giving me the opportunity to present this beautiful B3 lesion categories. Thank you so much.
Thank you. Thank you, Dr. Gaurav. That was indeed a wonderful presentation, and you very well clearly explained, especially the histopathology slides. Thank you so much. So without wasting much time, we will now proceed to the panel discussion. Our moderators are Dr. Arun Goyal, who is Senior Director, Surgical Oncology at Max Hospital, Vaishali and Patparganj. Dr. Vaishali Zamre, who is Senior Consultant, Breast Oncology at Rajiv Gandhi Cancer Institute. Next, please. So I would also now invite the panelists, Dr. Urvashi, who had been our first speaker, and Dr. Gaurav, the second one. Dr. Amit Agarwal, sir, is Director, Endocrine and Breast Surgery at Medanta Hospital, Lucknow. Dr. Kanchan Kaur, who is Director, Breast Surgery at Medanta, Gurgaon. And Dr. Ritu Verma, who is Consultant, Interventional Endovascular and Interventional Radiology at Max Hospital, Vaishali. Over to you, sir.
Thanks, Dr. Prikshi. And once again, I welcome all the faculty members, the panelists, as well as the attendees. Although Dr. Urvashi as well as Dr. Gaurav have actually comprehensively discussed both the topics, but we have a lot of students in the attendee platform and some budding surgeons as well. So there are certain practical issues related to both the topics we are going to now discuss in the panel discussion. Probably Dr. Ritu has still not joined. So we have 3 surgeons, and yes, Dr. Gaurav Khanna is also with us. So to begin with, I would actually like to ask Dr. Amit, sir, what are, just for the sake of our students in the attendee, what are the indications where we need, the use of localization techniques in our clinical practice?
Yeah, thank you, Dr. Vaishali. It was indeed 2 beautiful talks which set the tone for this discussion. I think the commonest thing is when you have a non-palpable tumor and you get some calcification on a mammography, that's the starting point for the rest of the investigations to follow. So, right. Sometimes you get 4 calcification on a mammography. Now you are in a fix what to do, and it's ultrasound, you see nothing. So that's a stage where you will require some kind of a localization, as Dr. Jain mentioned.
Yeah. Yeah. And Dr. Kanchan, would you like to add anything to that?
Yes, thank you. Those were 2 wonderful talks. So yes, for localization, post-neoadjuvant chemotherapy, if there is a clip in situ and there has been, a good response, which makes a palpable lesion impalpable, then yes, obviously we would require wire localization. And also now in this era of de-escalation in the axilla, if an axillary lymph node has been clipped, I know some centers do look at putting a wire. I don't know how much feasible that is in the axillary node for excision.
Sure. So the second question again to you, Dr. Kanchan. Dr. Urvashi actually mentioned a good list of localizing techniques. However, we do not have any of these modern technologies available to us. So what has been your use for the localization? What have been What is your practice? What do you use for
So,
localization?
yeah, so you know what? I know new techniques come, but it doesn't mean that you have to give up an established, safe practice that works for your setup. A lot of times in the West, there are other issues, like Dr. Urvashi was talking about scheduling issues. And, like when we talk about frozen, try getting a pathologist in the UK to do a frozen for you, So those are things which are guided by your practice, and how you work. For us, luckily we have a very good interventional radiologist, and for us, an ultrasound guided or a stereotactic via placement, depending on what the abnormality in the breast is, works very well. In fact, in my early training years, I spent quite a lot. In fact, Bristol Hospital used to do a training course for surgeons, where they used to train surgeons to do their own localizations, and I'd done that course. But ever since I came back to India and we have a trained radiologist, we have, at least I have lost the confidence to do that. But I think every surgeon should know a little bit about ultrasound guided wire placement, if we can do that, just so that we can, to make our life easy. But for us, all the other techniques that Dr. Urvashi spoke about are not available. And even if they were, I think out of habit or practice, unless the newer technique is more cost effective, quicker, I don't think I would want to change practice.
Right. Dr. Amit, what has been your use?
Yeah, I think I agree with Dr. Kanchan. I've been using the J-wire localization. It's worked very well.
Right.
Sometimes I put in a coil which is visible on ultrasound. So those two things work very well. But I would say it's not far when we have these new techniques coming to India. And I'm sure when we have our next panel discussion, we might have used a non-magnetic seed or something, definitely.
Yeah.
Okay.
So, yeah.
Yeah.
Please,
so,
one thing I would like to add, ma'am, considering the latest techniques, I think we don't have very strictly followed breast screening cancer program. Because in UK, the breast screening cancer programs are very strongly followed, and the frequency of those lesions, which are difficult lesions or the B3 lesions, are quite more frequent in those countries. While here we are not having so much very planned or very strict breast cancer screening programs. Once we start having these cancer screening programs, we will also have to develop these techniques, these identifiable, these localizing techniques.
you are right, Dr. Gaurav. You're
The
right.
frequency of these lesions are very less in our country.
So,
Sure.
Dr. Gaurav, I think the point is right. But one thing we have to realize is that probably we are not going to see a population-based screening program in India in at least near future. It is something far down. So, as of now, seeing the current situation, one thing I would like to stress is that both topics that we are covering today, they were somewhat marginal in importance till a few years ago. They're slightly increasing in importance, particularly when it comes to localization. It is again the increasing use of neoadjuvant chemotherapy, which is actually making it more important for us nowadays.
Yes.
B3 lesions, again, there will be some issues which you would like to discuss. So first and foremost, sir, Dr. Amit, in your practice, say what percentage of patients do you need to have localization? Say in a month, if you are doing 50 surgeries or 100 surgeries, what percentage do you need localization?
So, very good question. Over 25 years, of my practice, initially I never saw these lesions at all. There was no need for localization. For the last 5 years, I would say, the incidence is increasing. And particularly, when I shifted from an academic government institute to a corporate hospital, I think I'll be dealing more and more with these lesions. So I would say at least at this point of time, maybe 5 to 10% at most, you would require localization of the lesions, I see.
Dr. Kanchan, so what would you say 5 years ago and now? What is the change in the need for localization in your practice?
Yes, it has definitely increased because, as Dr. Amit mentioned, their private corporate hospitals and screening programs running in their executive health check departments. So this opportunistic screening plus this screening is leading to detection of smaller screen detected lesions. So definitely I would say it's gone up. I wouldn't be able to give you a percentage on that, but definitely it has gone up. Also, the trend of giving neoadjuvant chemotherapy, has really taken up in the past 5 years or so. So with regards to that as well, we have most certainly seen an increase in the need for localization.
Okay. So, Dr. Urvashi, now I would like to come to you. So, you have worked in India and then you are now in UK. So, there is a big change in practice. So, can we know whether in UK is a wire localization obsolete, or is it still used? Is it center-based, or do you use it in some cases?
There are still a lot of centers, Dr. Goel, in the UK as well that do use wires. It's not obsolete yet. It's also about health economics and, certain legislative processes that a lot of centers have to follow in terms of getting these new innovative technologies and techniques in the setup, really. So there are still centers that do use it. But like I said, we are now moving more towards these novel techniques, keeping the patient in center more than anything else in terms of comfort. And then, like I said, again, with scheduling is a big issue here. Theater time is paramount. We are told that an hour lost in theater it costs us about 600 pounds. Okay. And we don't have the luxury of a pathologist to do frozen sections. So if you try and work around costs with a pathologist who is there in-house, the theater time that it takes, especially if you're doing wider excisions, with oncoplastic techniques, to be able to do frozen for each of those, margins, shaves, the amount of time that, is required, I don't think the NHS would be able to afford it. So in terms of that, if they work out costs, it is definitely, from an overall perspective, a lot better to use some of these techniques.
So can we say that the major tangible benefit is logistics and scheduling, or are the other benefits really significant?
I would say mainly the scheduling and comfort.
Yeah.
What about the margin reoperation rates, the cosmesis? Do you think wire versus other techniques, like especially Maxid, do you think there is a difference in other aspects other than logistics?
I think, again, it very much depends on the radiologist you're working with, doesn't it? Because how they localize it for you very often, and how you're guided by that localization to take out the target is very important. With new technologies, in that sense, you're not as dependent on a radiologist. You have the seed in the center, you know where you have to go. It's very accurate. There's a lot of precision in that sense. You put the probe and you know where your target is. So you're not really relying on a lot of guidance from a radiologist in that sense, I feel.
So in a nutshell, you do you mean to say that with the use of, say, Maxid, you are able to excise the lesion more precisely compared to a wire?
In some sense, I would say yes. Okay. But of course, if you have a radiologist that you have been working with for so long, you've been doing those wire-guided excisions, and it works. It works for you. It works in your team. It works well. I don't see that there is anything wrong with having to do those. It's just that given that when you have the resources, then you want to utilize them to your best for your patient and, of course, for healthcare delivery overall. That's my perspective. But I feel that a lot of people change practice, especially in the UK, through pandemic as well, in terms of taking these newer technologies and newer innovations into practice, because we were operating, most of the centers in the NHS had to operate off-site. So we were not operating where our nuclear medicine department or radiology was.
Yes.
So for patients to have wires placed in one hospital, then go over to another hospital to get operated, that was very, very cumbersome.
True,
So
true.
max seed or any of these other techniques which allow you to place a seed in much before you can schedule the patient gives you a lot of flexibility.
So Dr. Urvashi, say there is sometimes a problem if the lesion is located deep. So have you faced a problem with the MagSeed because of deep location, or is that not a problem you feel?
No, I think again it is with experience and how.
And
I
is
think,
there a
yeah,
significant
sorry.
learning curve with say MagSeed or these technologies? No.
No, I feel in terms of learning curve, there is no learning curve. That
There
is
is
the
no
good
learning
part.
curve. Okay,
Yeah,
okay.
yeah, not much of a learning curve.
Okay.
As somebody very new to it, I feel like it wasn't such a difficult
So,
task.
Dr. Kanchan, you wanted to say something?
Yeah, sorry. I was saying for deep-seated lesions, wire placement is always challenging. So I don't know whether a MagSeed might be actually more useful for a wire placement. I mean, since I've never used it, I wouldn't know, but I would like to ask Dr. Urvashi to throw some light on that.
Yes, so with wire placement, sometimes I think migration is also an issue, isn't it? With these tumors that are located, either deep or even the fact if there is a lot of fatty tissue around, there can sometimes be migration. In that sense, I feel the MagSeed is much better because it will stay in place. There is no risk for migration either. I think Mr. Kothari wants to add something.
Yes, Dr. Ashutosh.
Hand up.
Sorry, thanks for letting me have a little word. So, all great talks. Thank you very much. Good discussion points. But I think, so Arun is making a relevant point where each probe has a limitation in terms of centimeters of how far it can read the seed. And that's about 6 centimeters at best. So it ranges from between 4 and 6 centimeters. But you have, what everyone forgets is the breast is a deformable organ.
Yes.
So all you have to do is just press a bit more because you know vaguely where the breast. So what is good practice is you should get your radiologist to put a skin mark on where he thinks the lesion is or whether he thinks the wire is. The seed is. So if you put your MagSeed probe in that area or localizer probe in that area, ballpark, you know it's in this area, and then all you have to do is squeeze downwards, and that distance obviates. So you don't have to worry about that distance at all. And then coming back to another point that Vaishali made about margins and wires and newer technology. See, the benefit of the newer technology is it allows you to sculpt your excision. So let's say you know where the seed is on a check X-ray. You know it's not placed bang in the middle. It's eccentrically placed. So you need to excise more laterally. You need to excise less medially, or you need to excise more superiorly, less inferiorly. You can actually work out on terms of once you hit the seed, because it gives you a 999 count. You can actually sculpt your excision like intraoperative ultrasound scan. So it is truly a guided excision. With a wire, it's more of a matka. You're hoping that this is where the tip of the wire is. And now I'm going to base my excision around this wire. So looking at just margin positivity or margin negativity in isolation is actually a misconception, or is actually wrong, because you have to also look at volume of excision. So and there is no study that has looked at this. So what we are doing is we are giving rough comparators to say, if I excise using MagSeed or if I excise using localizer or Savvy Scout or wire, my margin excision rate is the same. But no one is looking at, if I excise using one, am I actually excising less tissue? And the only study to have actually answered this is the Cobalt study, which looked at whether using ultrasound intraoperatively, it does reduce the volume of excision. So that gives you a kind of a guidance that if you have any kind of guided excision, your chances of excising less tissue are more than if you just have a blind guided excision. A wire guided is not a truly guided excision. It's a ballpark. You think it's in this area. As long as I get the wire out and then I look at the check X-ray, And then you have to look at how many more margin shaves I took. And none of them are actually looking at it. So I think in the long term, if you look at the benefits, not only scheduling, it's also the fact that you might end up with removing less tissue.
Less tissue, okay.
Yeah, thank you. That was a great input, Dr. Ashutosh. Moving on to the conventional wire, Dr. Kanchan actually would like to seek your opinion regarding when you send the patient to your radiologist for putting the wire, what all information do you seek from your radiologist before you take the patient to the theater?
Sorry, is this to me or to Urvashi?
To Dr. Kanchan, please.
Oh, sorry.
Yeah.
So, luckily for us, because this is a team which has worked together for almost 12 years, and most of the, so in fact, because if we have a patient that's come from outside and is going to be planned for a wire, at least I ensure that my radiologist gets to see the images and they don't come as a surprise to her on the day of surgery when I send the patient down for a wire. And after she's put the wire, see the mammogram films that are taken post-wire insertion are good enough. But sometimes if she's used some, some other way of putting it, it's far away from where the lesion is, or if she feels she's overshot it a little bit. The thing is, we are constantly communicating about the entry point of the wire, although I would have liked her to make a little drawing of where she feels the entry point is and the tip is, as Dr. Ashutosh said, it is a ballpark, estimate at the end of the day. But more often than not, that X-ray is good enough. And we talk about if there is any extra added information that she needs to give. And that seems to be working well for us.
Dr. Amit, I mean, generally, my practice has been wherever possible, I usually, go to the radiologist suite to, see the procedure being done in front of, me. Do you do the same when the wire is being put?
Not as much as I would like to, because of the logistics. But yes, the depth is important. So the radiologist would tell me the X plane and the Y plane,
Yeah.
And of course, the most important thing is accurate localization, because otherwise disfigurement will take place if you remove, sort of more tissue which is not required.
Right.
So the key is accurate placement. Depth is very important, I think. That's an issue which I discuss with my radiologist.
So, Dr. Amit, is the wire placement in your cases being done on the day of surgery or the evening prior? How do you schedule your cases?
The day of surgery. That's the best day.
Otherwise, day of surgery.
Its taping is done, and if there is a migration, it can create problems. So always on the day of surgery.
Dr. Kanchan, your case is also on the day of surgery?
Sorry, yes. So more than 99% of the time, yes, unless my radiologist is not available on the day of surgery and we need to put it a day prior. It's almost always on the morning of surgery.
Okay. And have you faced wire sort of migration?
So, if I say no, I haven't, I don't want people to think that we haven't done enough. So we haven't seen this complication. But honestly, we haven't, because I think that it's within a few hours of having the wire put in that the patient comes to OT. So, and I at least I haven't faced this problem as yet.
Dr. Amit, you?
I cannot recall
you
migration.
Cannot recall.
I'm sure the numbers are not very high to really give you a good idea.
Yeah.
So, Dr. Kanchan, I would like to seek your, idea about how do you plan your excision in whenever you're putting a wire for post-neoadjuvant, especially how much margin and how do you plan your excision when you put in a wire for post-neoadjuvant situation?
So obviously this will be highly individualized to what the pre-chemo or the presentation findings were, taking into account mammo, ultrasound, and if an MRI has been done. So a concordance of the final size on all the modalities, whether we needed to put one clip or whether this is a lesion that may need bracketing later on, and the decision on whether we are putting one or more clips. So that pre-chemo evaluation, obviously, whilst the patient is on chemo, the regular evaluation that we do to ensure that there is, a reduction in the size. If the goal of NACT was to downstage the tumor to allow breast conservation to happen. And then once chemo is over, we always ensure that if there is complete clinical response, we get, an ultrasound first to see whether the doctor will be able to identify it on ultrasound, because it's simpler to do ultrasound guided wire placement as opposed to a stereotactic, which takes more time and scheduling can be an issue. So before surgery, generally 2 weeks prior to surgery, when the patient comes for evaluation, we ensure that we know how the wire is going to be put into the clip and which modality will be used to guide it. And obviously the planning of the surgery, depending on how much tissue we are going to remove, basis what was the initial tumor size, what is the breast tumor ratio, whether we will need some oncoplastic procedure, what will be the placement of our incision, is obviously a very highly individualized decision that is made. So I think I haven't missed out anything.
So it is dependent. I mean, the extent of the radial as well as the deep margin will depend on the clinical and radiological assessment after neoadjuvant chemotherapy.
Yes.
Sure.
Yes.
So, Dr. Vaishali, there is one question which we can ask our panelists.
Yes,
in
sir.
patients with complete response to NACT, no lesion on mammography and without prior localization, how can we proceed for BCS? So maybe Dr. Kanchan and Dr. Amit could both answer that.
So that is a situation I will almost never want to find myself in.
But we do.
And
occasionally.
Yeah. So if my oncology friends have not been kind enough to, so this happened once, and after that we, ensured that it was drilled into the patient's head that if you don't have a clip, then it will be almost impossible to save the breast, so that they ask for it. Because this happened once, the patient had a 6 o'clock tumor and it completely disappeared. Patient was hell-bent on breast conservation. So I did a reduction mammoplasty for her, superomedial pedicle. So I was able to obviously get the entire inferior pole, but definitely not something that I would be comfortable doing. Yes, with larger, tumor breast volumes that you can remove with newer oncoplastic procedures. I don't think any surgeon in their right mind should think that they should be allowing breast conservation if a tumor bed has not been clipped.
Absolutely. Dr. Amit, your opinion?
I think I agree with Dr. Kanchan. I would never do a ghost lumpectomy, as it is known as. It's not advisable. If the patient is hell-bent, then you might do a cordonectomy with the oncoplastic procedure. But fortunately, I have not faced this.
So I can only add one thing here. It has happened once or twice that we did an ultrasound and we found a residual scar in the area of the tumor, which correlates very well with the prior imaging. So after explaining to the patient that this is based on the ultrasound findings and absence of any other findings, correlation with prior imaging, we could use this ultrasound scar to sort of localize. So I have done it in 1 or 2 cases, but again, it's not a situation which is very good or should happen. But it is, I would say that in India, NACT is now becoming used more and more. And sometimes it is happening that the patient took NACT in a peripheral place where there was no interaction with the surgeon, or the possibility of BCS was not discussed on day one. The medical oncologist assume it's going to be a MRM and didn't go for a localization. So we are facing this situation often on. Yeah. Dr. Rajiv, you wanted to say something? Yeah. No, you are mute.
This situation coming sometimes, as you rightly said, that the patient is getting chemotherapy outside, or the medical oncologist forgot to get the tumor localized by clipping, and patient is hell-bent. So as Amit said, sometimes we may have to do a quadrantectomy with some oncoplastic technique. That is the only way, but limited localized resection without a localization of the lump, I think one should not venture.
So I think we should move to the other area of B3 lesions. So Dr. Amit and Dr. Kanchan both, how often do you come across B3 lesions, given the fact that we do not have a lot of screen detected cases? So do you come across such lesions very often?
So,
Dr. Amit, please. Yeah. Go ahead, Dr. Kanchan, please.
Yeah, so we and as I just in the beginning of the talk did mention that numbers are increasing. We are seeing more and more of these, and because we do have vacuum assisted biopsy facilities available in our hospital, even MR guided vacuum assisted biopsies, a lot of these B3 lesions are being dealt by the radiologist, and we are not performing excisions on these unless obviously there's a rat path discordance or there's atypia or upgradation. So yes, we are seeing more and more of these. Definitely not as many as you would see in a population-based kind of a screening program, but we are seeing quite a few of these. I think Dr. Rajiv just mentioned in the chat box that we're seeing a lot of papillary lesions. So yes, we are, because more and more patients are coming to clinic and getting ultrasounds and mammography done.
Has Dr. Amit dropped out?
It looks like he's not seen.
Okay, so maybe we can meanwhile ask Dr. Urvashi. You would be seeing a lot of B3 lesions in your practice in UK. So can you just share some of your experience about B3 lesions?
Sure. I think it's not just population-based screening. That is definitely one of the aspects, but it's also patients who come into the clinic. So the ones that get picked up as opportunistic screening, which I'm sure you also see there. So some of them get picked up on opportunistic screening as incidental findings, and very often we pick up these B3 lesions with opportunistic screening. So most often it is an MDT-based discussion. I believe Dr. Gaurav pretty much highlighted all the guidelines, and we swear by VAB or vacuum-assisted excisions very often for most lesions which can be dealt with in a vacuum-assisted excision. I think what is of essence within B3 lesions is to look at whether there is atypia or not, because the upgrade rate changes significantly whether a lesion is known to have atypia or not. So that would be the first factor that would guide us towards what the next step would be, whether there is any atypia or not. And the other aspect of how you would want to deal with them in terms of having to surgically excise or do a vacuum-assisted excision, I would say are two factors which are key. One is the technical aspect. So if the lesion is supposedly too close to the skin, then it may not be feasible for the radiologists to perform vacuum-assisted excisions. But again, with experience and with some expert radiologists, there may still be a possibility where they're able to create a plane between the skin and the lesion by injecting local. That's something I saw with experience in some of the cases. And then the other aspect will be lesions where you want to look at the entire, you want to look at the lesion in its entirety. So for example, if it's a fibroepithelial lesion, then you want to look at the lesion in entirety. So you will want to excise the lesion. I'm sure the pathologists will tell you within the MDT that, they want to look at the lesion in its entirety to be able to give a thorough diagnosis. So those will be cases where we would want to usually surgery.
Can I add and ask?
Yes, please.
Yes. So, for small benign phyllodes, I don't know whether the practice in the UK is that if a complete vacuum-assisted biopsy has been done and it is a benign phyllodes, is there still a role for going back and getting a margin? That was one. Secondly, in the Indian scenario, a lot of our patients have FNACs, and the FNAC comes back as showing C3 atypia, and we see a lot of that. And then the patient ends up having an excision, and it could be a cancer. So I think if there are students in the audience, it's important that, if the FNAC is C3, that highlights even more the importance of image-guided TrueCut biopsy to diagnose and to understand, what the lesion is.
Yeah, that's very important for the students to take the message. Urvashi, what about her first question?
Yes. Sorry.
That was about small benign phyllodes.
Small benign, yes. Benign phyllodes, there are, with current guidelines, you don't want to take margins. We wouldn't want to take margins with a benign phyllodes. We wouldn't. But again, it's not something that will usually be typically diagnosed on vacuum-assisted biopsy. It would usually be a core biopsy, which will tell us it's fibroepithelial. And again, we will very much be guided by a pathologist. So we had Sarah Pinder at GUYS who would usually dictate our surgery as well during the MDT. Because she would be able to tell very often if it is borderline. If it is more towards a benign, then we would just do an enucleation, not with margins. And if there was a doubt, then we would do a wide excision.
So Dr. Amit is here, sir.
Yeah, sorry, my internet was disconnected.
No problem.
Yeah. So, sir, what is your experience with these B3 or lesions of uncertain malignant potential?
I think the commonest that I would see is the phylloids tumor, but I've seen those bigger ones. We have seen in India like 2 kilograms of phylloids tumor, but I haven't really seen small phylloids tumor. But yes, anything with atypia becomes more concerning. And so if you get atypia, then of course, vacuum-assisted excision, and that's important. I think today's breast surgeon needs to be well-versed with the vacuum-assisted excision, because we'll be seeing more and more of these lesions, which we didn't see 5 years back. And I think our pathologists would actually sort of guide us, what to do, the exact procedure, perhaps.
So one of the questions which I would say ask is, do we need more, say in our country, more sensitization of the pathologists towards the B3 lesions? Because I remember when it comes to DCIS, say 10 years ago, when we were having pathology reports of breast cancers, associated DCIS was reported very uncommonly, and nowadays a lot of reports have the details of associated DCIS. So I believe that is more sensitization of the pathologists which has happened, and maybe more thorough sampling of the specimens. So Dr. Gaurav, what do you think, whether we need to have more sensitization of the pathologists about breast pathology and these lesions?
Yes, sir, of course, we must sensitize the practicing pathologists, and in fact in the institution as well, because this B categorization is mainly based in UK practice. As per the CAP protocols, there is no defined B classification of neoplasms. Though we follow the CAP protocols for reporting in most of the, in fact, pan India we are following CAP protocol. And CAP protocol, it includes the dimensioning of DCIS and any other associated lesion, but it does not classify the lesions into B1 to B5. But yes, definitely it will be. It should happen that the sensitization of pathologists should be, and these lesions should be given importance, because they are very considering their association with the carcinomas or upgrade rates.
So, Dr. Kanchan, if you see a papillary lesion without atypia, is it your practice to put the patient on follow-up, or do you go for a complete excision?
So papillary lesions obviously broadly get categorized as symptomatic and asymptomatic. So if a patient has come with a nipple discharge and imaging is suggestive of a papillary lesion, or even if imaging is not suggestive of a papillary lesion, you do a nipple discharge cytology, which is showing papillary clusters, then obviously we do discuss surgery. And because most of these lesions are just under the nipple or close to the nipple areolar complex, it's simpler to do surgical excision than to try VAB. And it also allows the entire lesion to be seen in entirety. Now, for asymptomatic papillary lesions, I think I think we are a little, at least in my mind, I'm a little biased. And because in India, you don't know whether your patient is ever going to turn up for follow-up or not. We do end up, more often than not, surgically excising these lesions.
And especially there is no clarity about the follow-up imaging. I mean, how frequently, what kind of imaging?
No, but if there is no ATP and just a benign papillary lesion, then it's an annual follow-up. But if there is ATP, obviously, then individualized, you will go for more surgery. I just wanted to say here, Dr. Gaurav mentioned in his slide about solitary papilloma, you can leave, and multiple papillomatosis, peripheral surgery. But you are faced with nightmare situations sometimes where on the MRI, your radiologist just says multiple diffuse papillomatosis seen. Now, what are you supposed to do with that? And you can't surgically excise that. And I think if on a biopsy you've had a B3 lesion and imaging suggests that it's a large area, then again, there is this dilemma of surgical excision, because you cannot do a mastectomy basis a B3. And those are also challenging situations sometimes, where obviously the MTT discussion about rad path concordance, discordance comes into play. But more often than not in our practice, papillary lesions are excised.
Sir, one thing I would like to add here is that the papillary lesions, not only the difficulty lies with the clinicians, the difficult situation of diagnosing a papillary lesions lies amongst the pathologists as well, because they need extensive study of the entire lesion. And the biopsy, the core needle biopsy is, I've never seen a core needle biopsy and diagnosing a papillary lesion with confidence, because we don't know whether we are dealing with the entire lesion. And unless we are able to see the peripheral duct and we are able to highlight the myoepithelial cells, then only we can call a papilloma with or without ATPR. So it's a very big challenge for pathologists as well to diagnose a papilloma with confidence. So need of IHC and more and more extensive tissue examination is must to diagnose a papillary lesion.
Yeah, so if we have a BIRADS 4A on imaging, then more often than not, rather than doing a true cut biopsy, we will go for surgical excision, especially symptomatic papillary lesions. But only if it's 4B, 4C, then we will proceed to if VAB is needed or if a true cut biopsy is needed. But for benign appearing papillomas on imaging, generally we don't do a true cut biopsy to prove or disprove that this is a papilloma. At least that's the practice in our center.
Yeah. I think we are running short of time. So one just last quick question. Once we have excised these or done VAE and with clear margins, how do we follow these patients with B3 lesions? Anyone, Dr. Amit, Dr. Kanchan, anyone can take that.
Just to add, if I usually find if the patient is older, if there's calcification, or if the lesion is more than 0.5 centimeters, and it's higher BIRADS, then I would go for excision, rather than follow up. So these are my indications for operation.
I meant to ask you about after the excision has been done.
Yeah.
Now, how do you follow? And is there a role of, putting them on some chemo prevention or?
I would not follow any chemo prevention in these cases. And I think imaging, annual imaging perhaps is the only way to follow these.
Based on the patient's age, right?
Absolutely.
Yeah. Dr. Kanchan, do you want to add anything to that?
So obviously what the lesion was finally on excision, because, if it was completely excised, whether there was ATPR or there was no ATPR, also very importantly, family history, or a history of previous breast cancer in the same patient. So I think those are very important factors which would want us to follow up the patient earlier. The radiologist has a big say in this. If they start doing if and but about the MRI, and invariably most of these patients have an MRI, I think we end up doing more regular follow-up than may be justified. But yes, if a B3 lesion has been completely excised, and there are no other worrisome features that need follow-up, I think they can be sent back to routine screening, which would be annual.
Can I add something? Yeah. So
Yes,
if I
yes.
find there are multiple papillomas, probably I think more than 5, then there is a 3-fold increase of, malignancy. So these are the lesions who need lifelong follow-up. So multiple papillomas are concerning.
Right. Sir, Arun sir, anything else?
No, I think, see, the issues will never
Never
be
end.
over, but I think we have already crossed the time limit. So I would prefer that we close it, the discussion here.
So thank you to all the panelists, and over to Dr.
Thank
Chirag.
you, Dr. Rajiv.
Thank you. It was a
Dr.
great
Goel, Dr.
discussion.
Vaishali.
Thank you so
Thank you,
much.
ma'am.
Thank you, everyone.
Thank you, everyone. I feel that we have touched upon topics which are more commonly faced these days and less discussed. And to have a platform where we have discussed such extensively the important issues in breast cancer management, the localization techniques, and the B3 lesions from people who I would say are stalwarts in their field. And I hope we have been able to do justice to the topic. Thank you once again to all the panelists, all the attendees, and we'll be back soon with a new series of webinars. Thank you.
Thank you. Have a
And thank
great
you
day.
to Mice Ideas for wonderfully organizing and conducting this webinar. Thank you. And have a good night.
Bye.
Thank
Thank
you,
you.
everyone.
Thank you, everyone.
Thank you, everyone. Bye.
Thank you.
Bye.